Um, okay, so I hope you guys can hear. Uh, yeah. Okay. So I only have a slot of like 1.5 hours, so I can't discuss like each and every MCQ in detail. So I'll be going a bit fast. So if you have any doubts, you can ask me either in the chat or you can just unmute the mic and ask me. If I don't know the answer, then I'll go through the notes and everything and then get back to you later. Okay. Okay, so there were some questions in this paper. In this paper, you might have felt the questions a bit hard, but as far as I know, all these questions were from either the CAT exams or the ESA exams or some of the past repeat exam that we had gone through. So there might have been like more small modifications. So, but overall, it's a standard type of questions that have been asked till now. So as you go on, don't worry if you had thought like you are unable to do the paper or you felt like the questions are a bit too hard. Don't think like that. As you go on, you naturally get it. Like can do these questions by the time the end comes, you'll be able to do all these things. So most of these questions, so these questions range from BFM1 stuff, the CBSRS, GI, and some nephro. Yeah. So those are the questions that are here. So I'll be going through them. So initially there's like pathology, then pharmacology and microbiology. So I'll go through some of the in the order. So the first question is regarding acute inflammation. I don't think you would have found this question hard. You know the answer probably. The answer is like true, false. So yes. So basically, the hypersensitive reactions can cause acute inflammation. That's true. Acute inflammation means like there'll be warmth, swelling, pain, redness, and loss of function. No? Hypersensitivity is also a type of inflammation that happens because of the mast cell activity and so on. So many inflammatory mediators act during hypersensitivity. So it's a true statement. Vasodilation happens secondary to the relaxation of precapillary sphincters. That's also true. It's in the notes itself. So you can see this is the process of acute inflammation. Initially, there will be like vasoconstriction, mild vasoconstriction to limit the amount of blood that's going, but that's a very transient thing. And then mainly it will be the acute vasodilatation and increased vascular permeability. So that's why you get the edema and stuff. Vasodilation is why you get the redness, warmth, those things. And the retardation of blood flow slows down. Leukocytes go out of the blood vessel into the interstitial tissue. Fibrin formation, role of lymphatics also there. So vasodilation happens secondary to the relaxation pre-capillary. That's true. So when you see before you get the capillaries, so capillaries are like this, let's say, so they come from the arterioles. So these arterioles, before the capillaries start, the arterioles will have smooth muscle sphincters around them. So that allows us to control how much blood goes through the capillaries in the periphery so that we don't lose a lot of heat. So when acute inflammation happens, we need more blood to go through that thing. So because of that, the precapillary sphincters they relax, allowing blood to flow. And then fibrin formation can act as a barrier to localize the inflammatory reaction. That is what happens. So that's why the inflammation that doesn't spread throughout your body, only stays in a certain place. Scarring can be a subsequent sequelae of acute inflammation. That is true. Scarring means fibrous tissue formation. But you might think that's a chronic inflammation thing, no, but it also happens in acute inflammation. So acute inflammation has these kind of sequelae. Either it can resolve without any issue, there can be scar formation, organization meaning like granulation tissue forming, blood vessel forming, those things happen in organization, abscess formation, and chronic inflammation. So if acute inflammation happens again and again and again, it goes into chronic inflammation. Here, scarring can happen if the inflammation is persistent, if the acute inflammation is not going away, or if there is a severe tissue damage, and also cause scarring when it comes to acute inflammation. So leads to formation of transferate rich in proteins. That is false. Transferate is not rich in proteins, first of all, and it's an exudate that forms in acute inflammation. So because here the gaps between the cells widen, allowing proteins and fluids to go out of the capillaries. So that is actually exudate, not a transudate. Transudate happens when there is increased hydrostatic pressure or oncotic pressure on either side of the capillary. So that's false. Next one is about the chronic inflammation. Here, these are pure theories, so I don't know what they have to say about these things. You can read through these things. These are in the bats. So there are certain types of inflammation, types of chronic inflammation, chronic suppurative, chronic granulomatous, suppurative granulomatous, and foreign body granuloma. So those things are there. So fish tank granuloma is caused by a type of atypical mycobacterium. So that is a type of suppurative granulomatous. Normally in granuloma, you don't get neutrophils, so you don't get pus. Here, both of them are there. Pus is also there. Granuloma is also there. So that's in fish tank granuloma. There are other things here as well. So you can see fish tank granuloma is the main thing. Some fungal infections are there. And there is actinomyces, that's a fungal infection. So that is also a chronic suppurative inflammation. There you don't get granuloma, but if the fungal infection doesn't go away, it'll be a chronic infection. Okay, but you know that neutrophils act against fungi. So if chronic inflammation is there and fungus is mostly attacked by neutrophils, what happens? There will be a chronic suppurative inflammation. There will be pus there and it will be for a long time there. So in actinomycetes is a what's that? Here chronic suppurative one should be somewhere here. Chronic suppurative actinomycetes infection. Okay, because it's a fungal infection. Like lymphocytes don't usually work against fungi. Alcoholic hepatitis is a non-granulomatous chronic inflammation. There is no granuloma forming in hepatitis, alcoholic hepatitis, but it's a chronic inflammation. Rheumatoid arthritis is a non-granulomatous chronic inflammation. There is no granuloma forming. You know about rheumatoid arthritis; it happens in joints. So there's no granuloma forming, but there is like other kind of fanus formation and the other things are there, but there's no specific granuloma. Crohn's disease is a granulomatous chronic inflammation. So if you get a tissue sample, you can find granuloma in the large intestine because it's a chronic inflammation and there's also these kind of things happening. So these charts, these lists say about the infection. So you need to have an idea, basic idea, at least the main things you need to know. Tripanoma pallidum, chronic viral infections are non-granular matter. So you can simply remember viral hepatitis by this thing. Chronic non-viral, like leprosy, leishmania, those are chronic infections, but they don't have granuloma. Okay, the next one is regarding wound healing. So earlier it is true, false, true. Third one is about wound healing. So wound healing, there are some inflammatory mediators there. So you need to know the function of them. At least a few important ones you need to know. So one of them is VEGF. VEGF you need to know. And the other one is PDGF. So platelet derived growth factor, this thing. And I'm not sure, but you might need to know about this thing. So it's better if you know. So VEGF is one of the things that initiates the wound healing. So it gets the endothelial cells to come towards that place so that they can organize into a new blood vessel. So it causes increased permeability. It is very important for the lumen formation of the vessels, migration of the endothelial cells towards the area of injury, proliferation of endothelial cells. So anything regarding endothelial cells, it is VEGF. Okay. And then remodeling of the capillary tube. Mainly it's about capillaries. And then PDGF is the one that, so in blood vessels, you have intima, media, and adventitia. So the media is made out of smooth cells. So smooth muscle cells are migrating to that place because of PDGF. So one is VEGF, then PDGF. TGF1 beta is the one that stops the process. So suppression of proliferation happens because of TGF1 beta, or else there'll be continuous inflammation and these kind of things happening. So VEGF stimulates proliferation, that's true. Marfan can predispose to chronic wounds. That's true because Marfan's is a connective tissue syndrome. So if connective tissue is not forming properly, then there'll be no proper wound healing. Just like Ehlers-Danlos syndrome, vitamin C deficiency, and those kind of diabetes. So those are some of those things. And the other one is wound dehiscence is precipitated by coughing. That is true. Dehiscence mean the wound margins are torn apart. So normally, let's say the wound, this is a wound. So there'll be two borders of here's one part of the skin, here's the other part of the skin. So let's say we are suturing this thing. But because of chronic cough or whatever, this suture can go apart, or else the normal healing process will not happen properly, especially in abdomen. So the wound opens. So that is dehiscence. So that is true. Healing a primary intention has more inflammation secondary. That's false. Primary intention meaning we are intentionally making a cut, especially a surgical incision, so that has very low amount of injury. Because of that, there will be less amount of inflammation. The borders are very well like approximated, so it's easy to heal. So it has less inflammation. Wound will reach 90% strength by 6 weeks. This kind of information they are asking in the paper, so it's better to know the duration. So around 50% of the strength comes in 4 weeks, around 70% in 6 weeks. So 4 weeks is 1 month, and then 1.5 months you have nearly 70%, and then only by 3 months you get 90%. But you never get 100% strength in wound. So that's the thing that you need to know. It takes a long time. Initially it heals fast, and then it heals very slowly. And about pulmonary embolism, clinical silent 60 to 80% of cases. Most of the time, pulmonary embolism is silent because there will be small emboli. So small emboli are initially silent, but if there's multiple small emboli coming and staying in the lungs, then it can cause pulmonary hypertension. Okay, and a medium-sized emboli can obstruct medium-sized pulmonary arteries. So what happens if it blocks those things? Those areas will not be perfused. So blood doesn't go that way. So there will be VQ inequality, VQ imbalance. So you don't get proper oxygenation. So you'll have hypoxia, but you won't die suddenly because the rest of your lungs will still be giving you oxygen. But if it's a massive emboli blocking, let's say, a main pulmonary artery bifurcation, the saddle embolus, sometimes they ask this thing. So that's why I highlighted it. And then a large branch. So a lot of blood does not get oxygenated. So if a lot of blood does not get oxygenated, you get very low oxygen and you die. So there can be heart failure as well. And most thrombi occur in deep arteries, that's false. Deep veins of the legs, so that's DVT. Occurs as a post-surgical complication, again it's DVT. Pulmonary hypertension is a chronic complication. Yeah, that is true. So this is true, false, true, true. An embolism is a of a segmental artery, which is a small artery. It's smaller than the lobe artery of the pulmonary artery causes sudden death. No, it's a small artery, so you will not die fast. You might either get hypoxia or with time you get pulmonary hypertension. And then regarding tumors, so tumors is a very important area that you need to know. So sarcomas show predilection towards hematogenous spread. That is true. Sarcomas go through blood, and carcinomas go through lymphatics. That's the general thing. And carcinoma derived collagenases facilitate basement membrane. That's true. Because collagenases break down collagen in basement membrane, so making it easy for the cancer cells to go. Gliomas are more likely to undergo hematogenous spread than local. That's false. Gliomas happen, they are type of neoplasm that happen in our brain. But usually primary CNS tumors don't get metastasized easily. So they usually have local invasion. Because of that, you'll have pressure, mass effects and stuff. So they don't go through hematogenous very much. And most ovarian Krugenberg tumors manifest secondary to ductal adenoma of breast. That's less common. The highest is actually stomach cancers are the ones that go to the ovary through the peritoneum. Okay, through the peritoneum as a Krugenberg tumor. Krugenberg tumor is a secondary tumor of the ovary because of tumor cells coming to the ovary through the peritoneum, because the peritoneal cavity covers all the contents of the abdomen. So anything that's inside the peritoneal cavity, intraperitoneal organs, can easily let the cancer cells go to the ovary. So highest is stomach cancer, and the second highest is colon cancer. The principle of organotropism explains differential spread of lung cancer to adrenal cancer. That's theory. So you need to memorize it. That's true. Certain types of cancers like to go to certain organs. So that's why the lung cancer like to go to adrenal glands. Likewise, here you can see other types of cancers going to certain things. It's good if you know these things. At least know adrenal and lungs. The next one, malignancy causative factor. Adenocarcinoma breast that you need to know. HER2 proton go gene HER2 amplification is a type of protein amplification, or it's also known as ERBB2. ERBB2 is a gene, HER2 is a protein. So that amplification is can cause adenocarcinoma of breast. Also, there are other types of gene mutation causing breast cancers. One is MYC gene, TP53. These are not very important. But BRCA1 gene and BRCA2 gene, they can even be after SCA. So you need to know these things. Endometrial carcinoma Lynch syndrome, inherited mismatch repair, that is actually true. So anyway, in Lynch syndrome, it happens because of mismatch repair gene mutation. So if there is any kind of mismatch repair in our DNA due to replication, they won't be repaired. Usually, Lynch syndrome is associated with GI cancers such as colorectal carcinoma, stomach cancer, and stuff. Also, it can also cause other cancers in other places, such as the ovary, the endometrium. Okay, so think of it like GI plus female reproductive. The Lee-Frohman syndrome, RAS gene mutation, that is false. That's because of P53 or TP53 gene mutation. That's theory. Colorectal adenocarcinoma and ulcerative colitis. That is true. Ulcerative colitis, even like Crohn's disease, can cause colorectal adenocarcinoma. That's something you need to know because there is constant inflammation happening there. So it's easy to get cancer in those kind of constant inflammatory stressful areas. And cervical cancer, carcinoma, HPV induced overactivity of retin RBG. That is false. So what happens is HPV virus goes and attacks and goes into very in the transformation zone of the cervix. So there is a very weak kind of, and it secretes E6 and E7 proteins. Those proteins cause inhibition of tumor suppressor genes such as TP53 and retinoblastoma. E6 inhibits P53, E7 inhibits RBG. This is a very important thing you need to know. And then high in arteriosclerosis affects medium-sized arteries. That's false. It's the name itself is arteriolosclerosis. So it's arterioles and small arteries. Vessel wall, here you can see small vessel disease, high in arteriosclerosis and hyperplastic arteriosclerosis. Vessel wall is responsible for chronic hemodynamic stress. That is true. In benign hypertension, you get hyaline arteriosclerosis, and in malignant hypertension, that means suddenly there is very high pressure, so that can cause hyperplastic arteriosclerosis. And fibrillar necrosis in media characteristic, that's false. That happens in hyperplastic arteriolosclerosis. Causes granular contracted kidney, that's true. So when there's like long-standing hypertension and causes high arteriosclerosis, that causes reduced blood flow to the kidney, that causes contraction of the kidney. Okay, causes weakening of the vessel. That is technically false here, because here is a long-standing thing, is a benign thing. So there is no actual death of the endothelial cells. But in hyperplastic arteriosclerosis, there is fibrinoid necrosis. So there the endothelial cells die. So there it's very easy for the vessel to rupture. That's it here. So that's also false. So false true, false true. Regarding atherosclerotic plaques, infiltration of neutrophils and is common. This is true in neutrophils, macrophages, other inflammatory cells, inflammatory mediators going. Plaques are with most muscle cells are vulnerable to rupture. That's false. The the plaques that are vulnerable to rupture have either more lipids or a very thin fibrous cap. So you can like imagine, no, very thin capsule, so it can easily burst. Or if it has lots of fat, it has lots of oxidative stress. So then it can Rupture. Tunica media becomes thin and atrophic. That is true. That is the reason why it causes aneurysms. Atherosclerosis complication having acute plaque change. Yeah, that is true. So the when the plaque ruptures, then the contents go into the blood and then it can block certain arteries. Small vessels growing into the atheromatous plaque increase risk of hemorrhage in plaque. That is true. So when vessels are growing into the atheromatous plaque, then it can easily rupture and there will be severe bleeding inside. That's true. So those are like pure theory. Regarding IHD, so ischemic heart disease, symptomatic disease occurs when 75% is blocked. That is true. Till 70% occlusion, you won't get any symptoms even in exertion. After 75, more than 75 means when you exert, when you do exercises or something, you get chest pain. After 90%, then even without any exercise, when you're just sitting still or whatever, you get angina. Multifocal microinfarcts due to occlusion of intramural vessels. Intramural vessels mean very small vessels that go into the myocardium. So they are very, very small. So if those small vessels are occluded, only a small part of the heart will go into infarction. So those are called as microinfarcts. Silent ischemia and diabetes, that is true. Because diabetes people have diabetic neuropathy. So their nervous system properly, especially their autonomic system. So even when there is ischemia, they might not feel pain. They might not have any kind of autonomic symptoms associated with chest pain. So they won't know they had heart attack, not heart attack, but ischemia. So that is known as silent ischemia. Then embolism main cause, that's false. That is actually atherosclerosis. Atherosclerosis is the one that causes. I hope you can listen properly. Is the internet working fine? Okay. Is also true. So it's basically like semi, non-semi, whatever. When there's thrombosis, very rapid occlusion of the arteries. So then you get heart attack. Basically, they're non-semi, no semi. Either can happen. So if it's semi, also it's true. Which are the following features of left heart failure? So in left heart failure, what happens? The areas that is before when blood is coming from somewhere to left atrium, left ventricle, no. So the areas that are will have edema. So that's how it happens in like right heart failure as well. So it's easy. So what is before the left heart? That's the lungs. So there will be pulmonary edema. So any kind of symptoms associated with pulmonary edema, and if it's severe, it goes into pulmonary hypertension. So there will be congested lungs. This is true. This is false. This happens when there is increased right heart atrial pressure. Bibasal capacitation, true. Tarmac liver, that's false. That's in systemic edema. Bilateral ankle edema, that's also false. So this and this happen in right heart failure. The A and C, left heart. About rheumatic fever, right heart valves are more affected than left side. That is true. That is false. Because left side is more affected in rheumatic fever because it has more pressure, more turbulence, so more activity that is happening in the left side. So it's easy for it to get kind of damaged or to get lots of antibodies that are coming to the heart. They can come and react very fast in the left side. Right side heart valves are mostly affected, let's say, in infective endocarditis, especially in acute infective endocarditis because they are the pathogen is more virulent, so it can easily attack any valve. But the first valve it comes to is the right side because the venous blood comes to the right side. Here is the left side because here is more action going on, more turbulence and stuff. So it's false. Pharyngitis of group A, beta hemolytic, that's how it happens. Streptococcus pyogenes infection. Ash of bodies are seen in myocardium. That's a type of certain specific type of macrophages which are found in the granuloma in the in, sorry, the Ashok bodies is a type of granuloma that is found in the myocardium. So that's the name. The Anichkov cell is a type of macrophage you find there. It's a giant cell. Large friable vegetation, RALs, that is false. Large friable vegetations only happen in when there's an infective cause. So in infective endocarditis, it will be large. Here, it will be very small vegetations because of platelet and microthrombi. Septic emboli formation, multi-organ involvement, that is false. Here, there is no sepsis, there is no infection. Here, it's because of an inflammatory reaction. So here's aseptic embolization can happen, but that happens in a chronic rheumatic heart disease. There can be atrial fibrillation, so that can cause mural thrombosis. So those thrombi can go somewhere else and cause embolization. Even then, that is an aseptic emboli. That is a thromboembolism. But if there is a infective endocarditis because of the rheumatic heart disease, there can be septic emboli, but that's a very, very, very late complication, and it happens rarely. And then regarding infective endocarditis, subacute involvement of previous damaged valve can be seen. So if that's true, subacute means the pathogen is less active, less virulent, so it needs a previous damaged valve. So that is true. IV drug users are more prone to get staphylococcus aureus. That's true. Staph aureus easily comes through the skin into the blood when they use the same injection again and again. Acute IE causes prominent damage in the left side. Now I told you it's the right side because that's where the venous blood comes in. So IV drug means it's going to the veins now, so it should come to the right side. So that's false. Ring abscess coordinated rupture can be seen. That's true because it's a necrotizing purulent organism. So it causes abscesses. It's a acute infective endocarditis. In subacute infective endocarditis, you don't get abscess that much because they are not very purulent. Multiple blood cultures are indicated for diagnosis. You need at least 2 cultures saying positive results, I think. And then regarding cardiomyopathy, this is kind of a, it's nice kind of question, I guess. So there are 3 types which are dilated, hypertrophic, and restrictive. So the commonest form is dilated cardiomyopathy. That means the ventricles are very dilated. They can't contract easily. It's hard to contract. So that means there is a systolic dysfunction. In hypertrophic and restrictive ones, there is a diastolic dysfunction because hypertrophic means the walls are very thick, genetically thick or whatever. So these are some of the causes. Genetic causes are there. Most is genetic in hypertrophic. Dilated can be genetic, alcohol, myocarditis, hemochromatosis. Restrictive, something else, preventing heart from expanding. So it's like amyloidosis, fibrosis, or something. Okay. So in hypertrophic and restrictive, the ventricles cannot expand to their fullest. So there will be less blood coming into the heart, but they can still contract. Okay. Okay. So dilated cardiomyopathy, systolic dysfunction. That is true because it cannot contract easily. Hypertrophic causes systolic, false. That's a diastolic. Amyloidosis causes restrictive. That's theory. Yes, because it doesn't allow the heart to expand a lot. Amyloidosis happens because there is abnormal deposition of misfolded protein. No? So it cannot properly allow the heart to expand. In restrictive cardiomyopathy, ventricles are not dilated. That is true. They are not dilated. They are normal size, but they can't expand properly. So you can go through these. I'll send the document later. So if you want, you can go through the small diagram. It's the time is the issue here. Even now, it's a bit complicated. Regarding amyloidosis, it causes intracellular deposition. That's false. It causes extracellular. Always think amyloidosis happens outside the cell. Abnormal proteins going there and staying there. Amyloid proteins are the same morphological. That is true, but they do not have the same structural, chemical structure. They are formed due to different types of proteins. But all in all, when you look through a microscope, it will still look a pinkish, like very light pinkish color because they are just proteins. So morphologically, they are misfolded and look the same nearly. They have very linear appearance. They don't have branches a lot. So it's like morphology wise, like look wise is same, but chemically they are different. So that's true. Aging causes amyloid deposits in multiple organs. That's true. It causes amyloids in heart, pancreas, and spleen. Better, good to know. At least heart, you must know. They asked that. Secondary amyloid is commonest form. That is actually false. It's a primary one that's the commonest. Primary means not because of any kind of chronic infection, but purely because of there's some disease causing increased misfolding of protein. This happens. Amyloidosis due to chronic inflammation of AL type. No, AL is a primary one. So AL means in like multiple myeloma, know, there is a lot of light chains forming. So that is AL. A type is a chronic inflammation causing amyloidosis. Regarding pathogenesis of asthma, is a very common area you must know. Prostaglandins are preformed mediators. No, they are newly synthesized. So prostaglandins, leukotrienes are newly synthesized. Preformed ones are like something like histamine, serotonin, TNF alpha, something like that. So those kind of things, they are preformed. Here is vagus stimulation causes bronchoconstriction. That's true. That's like parasympathetic. Hyperinflation due to air trapping. Yes, because the lung cannot exhale completely. So each time we exhale, there will be small amount of air in addition remaining in the lung. So with time, there will be trapping of the air inside the lung. Various food items can also trigger atopic asthma. It's kind of like allergy. So it can happen because of dust, pollen, animal food, and food, anything. Something that causes allergy. T helper 2 cells, important role. That is actually true. That's a theory thing. So they go release interleukin 4, 5, 13. They activate B cells, allowing release of IgE. So those bind to mast cells, priming them for sensitizing them. So those that's the way the thing happens. In COPD, emphysema, more commonly pan-asthma, upper lobe. That's false. It's actually majority. It is centrilobular. So it's the central or proximal part of the acini, including the respiratory bronchiole, and not the distal alveoli. So at distal alveoli is spare. So that happens mostly in smokers. So this kind of thing happens more in the upper lobes, which is true. But pan-asthma means the whole structure of the alveoli, acini, respiratory bronchiole is affected. So it cannot be because of something like smoking or something, because smoking happens, so it usually go and blocks the proximal part. No? So the whole thing is affected. So there you think that there is a genetic component because the whole structure is affected. So that is because of the alpha 1 antitrypsin deficiency. So that's kind of a genetic kind of thing. So that happens more on the lower lung zones, it seems. You can think like it has more stress, no? It's like pressed together, no? So that means it's so the emphysema can happen down easier. I think it's the other way. I'll check. This thing I'm bit confused. Okay. Thin, tall, young people, emphysema, high risk of pneumonia, right? That is true because if they are thin and tall, then that means the lungs apex is in a very high position. So the apex is being pulled down by the rest of the lung parenchyma. So that because of that, if they have emphysema, they can easily burst and form pneumothorax. And the other one, hypocapnia causes vasoconstriction. That is true. That's physiology basically. Commoners in young adults, no, in kind of in old people who have been smoking for a long, long time or something like that. Asthma happens in a young age, COPD older age. Regarding lobar pneumonia, microscope resembles a liver. That's why it's named as hepatization. There are 4 phases: congestion, red hepatization, gray hepatization, and the resolution. So the hepatization in the name itself, which is like the consistency of a liver. Microscopically patchy consolidation in lung. That's what here they ask for lobar. So it cannot be a patchy consolidation. Patchy comes in bronchopneumonia. So lobar means there will be lobar consolidation. The whole lobe will be very consolidated. They'll be like very firm. Lung abscess in pneumococcal pneumonia, that's false. Abscess form usually in Klebsiella, Staphylococcus aureus, or anaerobic infections. Predominant inflammation is interstitial, that's false, mostly in the alveoli. Interstitial inflammation happens in atypical pneumonia. Okay. And bronchial breathing is present in resolution. That is false. Resolution means you're getting good. There is not much fluid inside your lungs. so there's not much fluid inside your lungs, you won't get a strange kind of noise. You won't get a bronchial breathing. Bronchial breathing happens when there is some kind of edema inside your lungs. So there'll be, exudate in your lung or some kind of inflammatory fluid inside your lung. So that means that you can hear bronchial breathing. But in resolution, all those exudate will be reabsorbed back into the body. So you won't get a bronchial breathing. You are basically getting normal. So in post-primary TB, so that's true, false, 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 false. Uh, and post-primary TB, patient in post-primary TB is not infective. That is actually false. Primary TB, mostly they are non-infective, it seems, because they don't have a lot of pathogens inside their body. Post-primary TB is infective because it happens when they have poor immunity, So because of that, they will have lots of pathogens, lots of TB by bacteria inside their body. Because of that, they can be infected. Apical lesions are common. That is true in post-primary. Um, Disease progression slower than primary. That's also true. It happens very, very late, years later. Tissue destruction is less. No, there is more destruction, but it's mostly because of our type 4 hypersensitivity rather than the bacteria. Extension of the inflammation to pleural and pleural effusion. That's true. Any kind of inflammation going to the pleura can cause pleural effusion. The predisposing factor of ARDS. So anything that can cause inflammation, infection, whatever. There are so many causes. Go through this list, and just basically everything is true. So sepsis, pancreatitis, head injury, viral pneumonia, inhalation toxicity, oxygen toxicity, DIC, anything, drugs, they can cause. Regarding lung neoplasms, squamous cell carcinoma has characterization that is true. Why? Because characterization means like there is some kind of differentiation. No? So squamous name itself is squamous cell. So squamous cell can get keratinized. So that happens. That is true. And I put some mnemonics kind of thing. So only two types of lung cancers are associated with smoking. So SSS, smoking, squamous carcinoma, and small cell carcinoma. The other two types, which are large cell carcinoma, is it large cell? Yeah. Or anaplastic carcinoma and adenocarcinoma, they are not associated with smoking. Adenocarcinoma commonest in women and non-smokers. That is true. You see, they've asked here. Paraneoplastic Cushing syndrome is usually associated with squamous cell carcinoma. That is false. Squamous cell carcinoma, in that carcinoma, it is PTH, PTH related protein is the one that is released. So basically, it's PTH kind of thing that is released. So what happens if there's lots of PTH? You'll get hypercalcemia, right? So here they ask Cushing. Cushing means ACTH, no? So Cushing, ACTH and cortisol. So cortisol, so that means ACTH should be high. So that happens in small cell carcinoma. Here's another mnemonic, small cell carcinoma, AA and 1C. So it's like ACTH, ADH, and calcitonin. So here is calcitonin. So it's like less calcium. Small cell carcinoma characteristic goes along septa. It's false, I think. It's mostly adenocarcinoma that goes like that. And adenocarcinoma is the one that happens in the periphery as well. Okay. So the alveoli mostly the periphery. No? Lymphangitis carcinomatosis is a complication of primary lung cancer. I think it is true. Lymphangitis carcinoma basically is a complication happens because lots after very severe cancer, the cancer cells are now going through all the lymphatics of the lungs. So that is lymphangitis carcinomatosis. So all the cancer cells are going through lymphatics and they are causing inflammation of the lymphatics. So that's also true. So true, false, true, false, false, true. And 21 pulmonary edema and mechanism. So left ventricular failure. So here's the mechanism. So you can go through this later. Better to go through this after this thing. Left ventricular failure, pulmonary vascular edema. No, in left ventricular failure is mostly the hydrostatic pressure, the back pressure that causes pulmonary edema. Renal failure increase hydrostatic pressure. That is true because renal failure means there is retention of fluid inside your body. It's not excreting water a lot. So there will be increased hydrostatic pressure, and also there will be hypertension and so many other things happening. Pneumonia, lymphatic obstruction, that is false. Pneumonia is mainly because of inflammation causing exudation of fluid into the lungs. Toxic gas inhalation, direct alveolar inhalation, that is true. If the walls are damaged, then it can easily cause edema. ARDS also, the mechanism behind is actually neutrophil mediated endothelial damage. Neutrophils get randomly, erratically activated because of there will be inflammation. Inflammation causes edema. That is true. So regarding peptic ulcer disease, epigastric pain is worsened by food. That is false. So yeah. So peptic ulcer disease means there is lots of gastric acid that is produced in your stomach and it's not properly neutralized, causing ulceration of the mucosa. So if you eat food, then the food will actually buffer that acidity. So the acid's power will go down. So you won't get pain when you eat. But in GORD, you get more pain when you eat because there it is a reflux of the acid from the stomach to the esophagus and towards some there's a regurgitation. The acid is coming up. So when you eat, now the esophagus is relaxed. Relaxed means like the sphincters open. So more acid can come back up. So there will be more pain in GORD. Zolling-Ellison syndrome is a causative factor. Yeah, that is a true. So there it can have like iron deficiency anemia, also associated with some kind of esophageal cancer, I think, and this gastrite, peptic ulcer disease as well. So that's true. Commonly affects the proximal part of the duodenum. That is true because duodenum, the proximal part is the one that gives a lot of concentrated gastric juice after it exits the stomach. So more damage there. Gastric ulcer, rugal falls, conversion ulcer. That is true. In gastric adenocarcinomas, usually if there are ulcerated kind of things, they won't have rugae towards those ulcers. But in a normal peptic ulcer, there the rugae will converge towards the ulcer. Chronic gastric ulcers are rough and covered in debris. That is, chronic is smooth and clean because it is again and again digested by the gastric juice. If it's acute, then it might have debris because there is bleeding, hemorrhage, there will be digested red blood cells there. So that causes a black spot kind of image, blackish spots or blackish brownish base there. So here's this is false. So it's false, true, false. Hepatitis, most infections are subclinical. That is true. In acute hepatitis, prominent eosinophil inflammation in acute alcoholic hepatitis. That is false. Acute alcoholic has more neutrophil because it's kind of like an acute inflammation. No? So neutrophil, and you can see Mallory bodies, which are typical finding there. Eosinophilic infiltrates are commonly found in drugs. So drug is kind of kind of causing like allergy kind of thing. So you can think of eosinophils being higher in drug-related hepatitis. Portal tract changes are more marked in acute. No, portal tract changes are more marked in chronic hepatitis. Acute hepatitis will have more lobular changes. So there will be lobular dysentery, something like that. Hepatitis B associated high risk hepatitis like carcinoma, that is true. Confluent necrosis is a feature of acute severe hepatitis, that is true. So there will be severe necrosis in some types of acute hepatitis. There is severe necrosis causing a type of necrosis called confluent necrosis. Like lots of areas are necrosed, so now they join together those necrosed area. Regarding inflammatory IBD, stricture is common and ulcerative compared to Crohn's. That is false. Crohn's disease has more deeper ulcers. It penetrates through all the layers of the colon. But ulcerative colitis only affects the mucosa and submucosa. It doesn't even go to the muscularis propria. So because of that, strictures are why stricture happens when there's damage to the muscles, the smooth muscles, they contract, or there is like fibrous tissue formation in the muscle when there's muscle damage or deeper tissue damage. So that happens in Crohn's. Transmucosal inflammation in ulcerative colitis, that's also same thing, but transmucosal means like going through the layers. No, that's it. Crohn's. Endoscopy is cobblestone appearance. That's also Crohn's. Cobblestone appearance happens because in Crohn's disease, there will be like serpiginous, like uh, this kind of tracks, kind of ulcers. Okay, they'll be like deep ulcers going something like this. Okay, so it like this kind of ulcers. Okay, so these areas in between will have normal tissue, but these areas will have a very deep ulcers. So that looks like cobblestones. Cobblestones mean like in all, like if you have gone to like golf fort or something, you might see there's the stone is like cobbles, like the pavement is like they have a path, no, the pavement kind of thing. So they have very deep fissures in between the stones, and you step on the stones to walk. So the stones will be the normal tissue here, and the deep fissures will be the gap in between. Toxic megacolon is complication in ulcerative colitis. Yeah, that is true. In ulcerative colitis, when it's very severe, it can even affect the muscularis propria. But ulcerative colitis is a very, how to say, it's a widespread inflammation. So Crohn's is more deep. Ulcerative colitis is more widespread. So it's a huge area. So if the muscularis propria is affected, then the enteric nervous system will also be affected. Because of that, the colon will not work properly. There won't be proper contractions, there won't be proper motion. So that cause toxic megacolon. There will be dilatation of the colon. Extra intercellular manifestation suggests Crohn's compared to ulcerative colitis. That is false. Both are nearly the same types of extraintestinal manifestation. So you can't like differentiate based on that. GI polyps, hematomatous polyps are neoplastic. No, they are not neoplastic. The other two types are hyperplastic and inflammatory polyps, and hematomatous polyps are not neoplastic. This is theory, so you need to memorize. The neoplastic ones are adenomatous polyps and adenomas and I think sessile polyps, I think. Yeah. And then Peutz-Jeghers syndrome is associated with STK11 gene mutation. They had asked this question, so it's very good. So it's true. It's a theory. Peutz-Jeghers syndrome is a type of polyposis syndrome. Most adenomatous polyp progress to adenocarcinoma. That's false. Only a few progress to carcinoma. FAP occurs due to mutation in gene mismatch repair. No, that is false. FAP occurs due to mutation of the APC gene. So it's in the name. Familiar adenomatous polyposis. No. So the gene's name is adenomatous polyposis. I don't know what C means, but APC gene. Okay, that is in the chromosome 5. It was actually asked during one of our lectures, I think, in the clinical science. So mutation in DNA mismatch repair gene, that happens in Lynch syndrome, or it's also known as HNPCC. Hereditary non-polyposis HNPCC, right? Hereditary non-polyposis syndrome, carcinoma, colon carcinoma. And then tubular adenoma have higher risk of malignancy than villus. That is false. In a normal histology of the colon, it has tubular structures. No? So it has like it goes in. So there'll be like tubular. There'll be tubules. There'll be the epithelium is like the epithelium is famous. Column epithelium in tubules. So it will have tubules. So it is more closer to the normal structure. Because of that, that has less chance of going into a actual carcinoma. But villus villus is found where villi are found in the small intestine. So that is not the normal architecture of the colon. So there, if these kind of cells are found in colon, then that means it has a higher risk of going into carcinoma. So that's how you remember those. So villus adenoma has a higher chance of malignancy compared to tubular, which is the normal kind of a normal architecture to the colon. Regarding interstitial ulceration, typhoid gives rise to ulcers causing strictures. False. Typhoid resolves without any stricture. That's the important thing to know. It occurs in a longitudinal fashion, doesn't cause strictures. Yeah. And TB, It causes strictures because it's a deeper one, and it happens in the transverse plane, transverse ulcers, not a longitudinal ulcer. Intestinal TB presents ileocecal mass. That's a theory you need to know. It's one of the DDs if you find a right hypochondrial, sorry, right uh, biggest yeah, the right lower quadrant mass, if you find something like that, then it's like that. And flash shape ulcers in amoebiasis, that theory, yes, pseudomonas colitis due to Clostridium tetani, that's all, Clostridium difficile. Again, necrotizing enterocolitis in neonates, true. So it's kind of like intestinal bacteria invading their own immature epithelium and causing inflammation. That's causing necrotizing enterocolitis because they don't have proper immunity sometimes, or sometimes there's some improper feeding, so something like that kind of cause it. Primary glomerular diseases are typically give rise to nephrotic syndrome. So you need to know which types come under nephrotic and which types come under nephritic. So nephrotic syndrome is most like proteinuria and those kind of things happen there. Okay. So here, membranous glomerulonephritis, FSGN, so focus segmental glomerulonephritis, and minimal chain disease come under nephrotic syndrome. All the other ones come under proliferative. Even in diabetic nephropathy is also a part of nephrotic syndrome. It has actually both. It can have both nephrotic and nephritic features combined usually. Diabetic nephropathy. And 28 regarding kidney injury during AKI. So in a hypovolemic shock, that means there is less blood going to the kidney. So that can cause kidney injury. Here, the tubular membrane is intact. That is false because ischemia causes what? Less blood supply to the tubules. So that can cause. So the basement membrane is the one that gets oxygen and everything from diffusion. So there's less blood going there. There'll be less oxygen coming to the basement membrane and the epithelial cells. So they will slough off. They will die. So even the basement membrane will be affected. But let's say if this is a type of a nephrotoxic nephritis, let's say some person ingested some kind of toxin that goes into the kidney and so on. So there, it is the epithelial cells that die because they are the ones that are in contact with it. But basement membrane will not be affected then. PCD is more affected than DCD. That is also true because there is more active secretion and everything happens. So there's more energy need in the PCD. So it dies first. Slough tubular cells from tubular cast, that is true. The dying cells go into the lumen, so then they get modified because of those things. The name is known as casts. Glomerular show proliferative change is false. Here, cells die. They don't proliferate because there's no inflammation. Marked interstitial fibrosis is a feature that only happens in chronic interstitial nephritis. This is acute thing, no? So there won't be a fibrosis here. In RCC regarding renal cell carcinoma, clear cell carcinoma has homogeneous gross appearance. That is false. It's known as a variegated appearance. There'll be so many things there. There'll be like bleeding, hemorrhage, fibrosis, necrosis, and so many things happening there at the same time. So we'll have different gross heterogeneous appearance. Tendency to go towards into the renal vein. So from the kidney can go to the renal vein. Sarcomatoid differentiation, good prognosis, that's false. Chromophobe carcinoma has the best prognosis compared to clear cell carcinoma or papillary renal carcinoma. Sarcomatoid has very bad prognosis. I think it's rhabdoid differentiation has a better prognosis than sarcomatoid, I think. Associated with von Hippel-Lindau syndrome, that's theory you need to know. Yeah, it's a type of syndrome which can cause renal carcinoma, including hereditary leiomyomatosis and hereditary papillary carcinoma. Polycythemia is a known manifestation. Yeah, it's because of the paraneoplastic syndrome. The easy way to remember what kind of paraneoplastic syndromes can occur in a renal cell carcinoma is this thing. So think of it as pteroneoplastic syndrome. So for each letter, remember the hormones that are released in renal cell carcinoma. So PTHRP. So the same thing came in where the squamous cell carcinoma. So here's also there. E, erythropoietin. You know the kidney is the one that secretes erythropoietin. And A, ACTH. It's a name. R, renin. So kidney is the one that secretes renin. So here also it can be secreted. So that's how you remember the peyronieoplastic syndrome. Remember it as a mnemonic. They might ask this. Regarding cystic renal disease, adult polycystic kidney disease can progress to end-stage kidney disease. That is true. In children, like childhood polycystic kidney disease, they die early. So they won't probably go into a CKD. They will die early. That's the thing. But it is always associated with liver disease, childhood PCKD, not like in adult one. Dialysis associated cyst can see metalysis. Yeah, both metal and cortical cysts can be there. Childhood PCKD occurs with mutation PKHD1. That's theory. It is true. In adult, it is PKD1 and PKD2 gene. PKHD1 gene is for childhood PCKD. Metal sponge kidney disease was the name itself. There can be whatever affects the kidney can cause renal impairment. No. Simple renal cysts are usually seen in the cortex. Yeah, cortex is yeah. So now you finished pathology. Hope you had some idea of what I was talking about. We've gone through at least half of the document. Okay. So now let's go into. Hope I'm not rushing too much. Hope you have some idea of what I was talking about. You can give a question, at the end if you want, or at least use the time. Okay, regarding elimination kinetics, so this is pharmacology. So here curve in plasma concentration versus time plot is linear zero order kinetics. In zero order kinetics, the elimination rate, the excretion rate will be constant. So there will be this kind of a straight line there. The concentration will go down in a constant manner. In a first order kinetics, it will go like this. Initially, it will go very fast, then it slows down. Elimination rate proportion to drug concentration in first order kinetics. Yeah, that is it. Phenytoin shows zero order kinetics within therapeutic range. Yeah, in therapeutic range, phenytoin causes forms zero order kinetics as well. So it has both first and zero order kinetics. So that's why when you're increasing phenytoin, when you want to increase phenytoin, you don't go in a proportionate manner. You increase it very, very small increments, because if you increase by a proportional manner, the total concentration will go very high, because the elimination rate will not increase proportionately. So it will remain the same, but you give, let's say, 1 gram more, then the concentration will be going very high up, because the elimination can't keep up. Risk of toxicity is high in first order, it's in zero order. Yeah, because we don't know, right? So we don't know when first order becomes zero order. In first order, the more we give, the more will be eliminated. So that's easy for us. So toxicity is comparatively low. Drugs with first order kinetics as variability of no, they are constant. Which of the following is true regarding the dose response curve? This was not given in the paper, sorry. So this is the curve. So here you can see A has efficacy of 100, B has around 70, let's say 65, 70 range. Okay. So here B acts as a full agonist, that's false. A is the full agonist. Full agonist means it has 100% efficacy when binding to the receptor. A can produce maximum response at the receptor, that is true. So A is a full agonist. If binding of A and B is reversible, response reduces when B is increased. Yeah, because A and B are competing for the same place. So when you increase B's concentration, then more proportion, let's say initially it's like 10% B and 90% A, but this 90% A causes 100% effect. Okay, and this 10% B causes, let's say, 10% effect. So now we are increasing this to 20 and this is 80%. So 20% B and 80% A. Okay. So now This 80% A will give us, let's say 80% effect. So earlier it is like 90%, 90% and 90%. Here is now 80% and 80%. But B increased like 10% also. It's like 20%. It's like, so how do you say? It's not 20%. Yeah. 10% gave 5%, and there was 90%. Let's say totally 95% activity. Let's say now 80%. So now we are giving 80% activity from A, and we have increased B to 10%, 20%. So 20% B will give us 10% activity. So totally there is 90% activity. Initially it was like 95%. Now it's 90%. So if you think about it, you can get it. I'm going a bit too fast. So yeah. So when B's proportion is increasing, the total effect will be decreasing. So that is basically, it's kind of acting like a antagonist. It's decreasing the effect. Tamoxifen is an example for B when estrogen receptors are concerned. That is true. Tamoxifen is a competitive inhibitor or partial agonist for the estrogen receptors. It has less efficacy than estrogen. B can act as a competitive antagonist at the receptor. That is true. That's what's happening here. And then lipid lowering agents and their mechanism of action. So this you must know. So lipid lowering agents and their mechanism of action, their adverse effects, certain special characteristics, certain special pharmacokinetics, you need to know. They can ask. Profibrate, it's a fibrate. Isn't they say it's the agonist of PPAR alpha. So that is actually true. Ezetimibe, they're saying the bile acid sequestration, but no. Ezetimibe is a cholesterol absorption inhibitor. It inhibits the absorption. Bile acid sequestration, for example, we can say cholestyramine. So that causes that drug, if you swallow that drug, that binds to bile and prevents reabsorption of bile into the circulation, not cholesterol. So along with bile, cholesterol will also go up. Cholestyramine, so that's false. Nicotinic acid is inhibiting hepatic triglyceride VLDL production. That is theory, so I don't know what else to say. It's true. Antihypertensive in the mode of action correctly compared. Losartan, it is a ARB, angiotensin receptor blocker. So it inhibits aldosterone receptor secretion. That's true because angiotensin 2 is the one that induces aldosterone secretion from the suprarenal gland. Nifedipine reduces cardiac output. No, it is a CCB, it's a calcium channel blocker that blocks mainly the smooth muscles of the vessels, and it causes reflex tachycardia in the heart. So technically, it increases cardiac output. Hydralazine, direct vasoconstrict dilation. That is actually true. So that's theory. Methyl-lopa is a centrally acting vasodilator. So it inhibits sympathetic outflow. That's also true. Prazosin is an alpha 1 blocker. Okay. So that's why it causes peripheral vasodilatation. Alpha 1 receptors are the ones that are responsible for vasoconstriction in the periphery. Here is the alpha 1 blocker. Medicine survival benefit for heart failure. These are the categories. So you need to memorize this thing. So these are the things. These are the drug classes that have survival benefit. ACEI, ARB, ARNI, beta blocker, SGLT2 inhibitors, and mineralocorticoid receptor blocker. So furosemide is a loop diuretic. So that is false. Empagliflozin and dapagliflozin. Yeah. Empagliflozin is a SGLT2 inhibitor. Bisoprolol, metoprolol, carvedilol, atenolol, those are beta blockers. ARNI. Enalapril is an ACE inhibitor. Prils are ACE inhibitors. Sartans are ARBs. True false. Then clopidogrel is a cyclin inhibitor. That's false. It's a P2Y12 inhibitor. Cyclooxygenase inhibitor. What is that thing? There's an NSAID. No. So this is a P2Y12 inhibitor, or else you can also say it's an ADP receptor blocker. ADP receptor inhibitor. So that inhibits the clotting, basically inhibits the activation of platelets. So loading dose of clopidogrel is given before percutaneous PCI. That is true, it seems. You give clopidogrel to prevent block thrombus formation when you do a PCI. You also give a loading dose of aspirin. So this is important thing. So you give uh, dual antiplatelets before you do the PCI. Tenecteplase is a recombinant tissue plasminogen activator. That is false. It is a bioengineered TPA activator. TPI activator, plasminogen activator. Recombinant tissue plasminogen activator is altiplase. Altiplase is recombinant. Tenecteplase is bioengineered. There's a difference. Tenecteplase is administered intramuscularly. No, it's an IV bolus. You just give one IV bolus. So that is why tenecteplase is more preferred than altiplase. Altiplase, you have to give a bolus, and also you should give, you should also give IV infusion as well. In tenecteplase, you don't have that issue. And then streptokinase is safe to re-administer in 1 week. That's false. It's contraindicated to give after 4 weeks because it is a foreign body kind of thing. So when you give, what you do is like after 4 days, you get the sensitivity for that thing. So when you give it again, what happens is that you get hypersensitivity reactions and other allergic reactions if you use it after 4 days. Okay, and you let's the thing. So that is false. 37 pharmacodynamics of anti-anginals. Nitrates predominantly produce base, so dilatation of veins. That is true. This theory. Verapamil is a calcium channel blocker, is a non-dihydropyridine, causes negative inotropic. Yeah, that's one of the things. It increases the activity of calcium channel blockers of the heart. So that is causing, yeah. And nicotinamide acts by blocking potassium channels. That is actually, what have I written? Yeah, that's also true. It actually, so no, it opens potassium channel blockers. See, potassium channels. What the 11? It opens potassium channels. Ivabradine blocks carbonyl alpha-1 antagonism. Yeah, that is true. It's a non-selective beta blocker and alpha-1 blockade. It's a nice effect, I guess. Ivabradine blocks the funny currents in cardiac channel. So this is a like funny thing to remember. Ivabradine inhibits the funny channel. So it's a strange thing. So remember like that. Regarding mechanism of action of anti-arrhythmic drugs. So anti-arrhythmic drugs, there is a table in the batch or something about which class of anti-arrhythmic belongs, what affects what channels, and which drugs come under which class. Like that's class 1, 2, 3, 4. So you need to know what drugs are the examples of it, as well as what is the channel it affects. Is it a sodium channel, potassium channel, beta blocker, or whatever? So you need to know. Here's the basic thing. So effect mainly on ectopic pacemaker cells more than normal cells. Yeah, that is true. Because you don't need antiarrhythmic drugs to act on normal cells. You need to act on abnormal pacemaker cells. So that is true. Action on abnormal conduction is prevention of re-entry. That is true. So you don't need to have, you don't want signals from the ventricles to come back into the atrium. So you want to stop that action. Mostly act on resting ion channel? No. You need antiarrhythmics to work on erratically or wrongly working ion channels. So you want to regulate their rhythm, right? So you don't want it to act on normal resting ion channels because they are not working at all. You don't need to close them. Mainly act on depolarized tissue more than normal polarized tissue. That's also true. Same thing, they are giving different words. Most are positively inotropic. No. The positive inotropic ones, that means they increase the contractility of the heart, are only digoxin and amiodarone. All the others reduce the contractility. And then serotonin inhibits platelet aggregation. This you would have learned in physiology. And this induces platelet aggregation. So it's false. Negative inotropic effect, it has a positive inotropic effect on the heart. Antagonist have prokinetic effect on GIT. False. Its agonist have prokinetic effect. So serotonin is one of the things that is released when you swallow something. When it goes through the esophagus, serotonin neurons, serotonin releasing neurons are the ones that are usually activated. It modulates pain perception, basically everything. Yeah. It's mainly synthesized in the nervous system. No, it's mainly synthesized in the GI. So it's the colon, it's in the stomach and small intestine. Regarding medicine, the parasympathetic division of this thing. So pilocarpine is a direct acting alkaloid. It's a theory. It's used in open angle glaucoma. So it's a muscarinic drug. So it's a muscarinic drug. So muscarinic is a parasympathomimetic drug. So yeah, atropine is contraindicated in myasthenia gravis. That is true because atropine blocks muscarinic channels. In myasthenia gravis, you don't have proper acetylcholine receptors already because they've been attacked by antibodies. So you need more effect rather than less effect. Atropine blocks even more channels. Carbachol is not degraded by acetylcholine. That's true. Carbachol is a choline ester, it seems. So it's not degraded by acetylcholine. Atropine is more effective than pyridoxine against nicotinic effects of organophosphate poison. That is true. Atropine acts on muscarinic receptors. Okay. But nicotinic receptors are the other type. No? So for that, you need pyridoxine because pyridoxine breaks the phosphate bond from the uh, cholinesterase enzyme because in organophosphate poisoning, the phosphate group binds to the cholinesterase enzyme, inhibiting the enzyme's activity. So because of that, there will be excess amount of acetylcholine in the NMJ and everywhere. So now you want to return it back to normal. So you cleave the phosphate from the cholinesterase. So pyridoxine does that. So it also works in nicotinic receptors as well. Cholinergic drugs are indicated for intestinal obstruction. That's false. Cholinergic drugs cause even more motion or contraction of the intestine and whatnot. So it causes increased buildup of pressure. You already it is obstructed. So you don't want more pressure pushing from one side. So it's contraindicated. Type B adverse effects differs from type A adverse effects because type B are more common than type A. That is false. Type A is common. Type A is the one that is depending on the concentration of the drug. So if the drug you mistakenly give more concentration of the drug to a person, then the effect will be type A adverse. Type B is a bizarre effect. So that means there is no relationship between the actual action of the drug and the adverse effect. Because also will be getting weird adverse events. So, for example, anaphylaxis. Sometimes there'll be other SJS, some weird other adverse effects. You get like hepatitis for certain drugs. Dependent on therapeutic index of the machine, that is also type A is the one that is dependent. Can be predisposed by medicine interaction. It's also type A. Medicine interaction either increase the activity of the drug or decrease the activity of the drug. So activity of the drug is the one that is connected to type A adverse effects. So here also it's wrong. Response value to dose reduction, same thing, type A. Frequently occurs in medicine with short plasma inflammation, same thing, type A. Anything related to the drug dose is type A. Following correct drug and MOA, ipratropium inhibit PDE, that is false. Ipratropium is a SAMA, short acting muscarinic antagonist. So it should inhibit the antagonist, it should be antagonizing the muscarinic receptors. Theophylline, which is a methylxanthine, muscarinic, that is false. It's actually the first one. So theophylline inhibits PDE and increases CAMP. Okay. So because of that, there will be bronchodilation. Montelukast, some people will be using this thing. Montelukast is a leukotriene receptor inhibitor. So that is true. Sodium chromoglycate is a mast cell stabilizer. So it inhibits the mast cells from releasing cytokines and whatnot. Formoterol is a LABA. It's a LABA. LABA is long-acting beta agonist. Here there is antagonist, so it's wrong. Regarding anti-tuberculous medicine, ethambutol was reversible. These are like theory things, no? Ethambutol was reversible optic neuritis. That is true. Isoniazid acid inhibits cell wall synthesis of mycobacterium. That is true. It inhibits the mycolic acid synthesis, which is a part of the cell wall. Rifampicin causes orange color urine. It's a very famous question. It is true. Pyrazinamide is an inactivated acidic base. That is false. Pyrazinamide works inside the macrophages because it is acidic. So it's exactly the opposite thing here. Streptomycin is given once a week in adults. False. It is intramuscular once daily. Even I didn't know that, but they've asked this question. Why? I don't know. Regarding antiemetics, dyskinesia effect adverse effect metoclopramide. It is true. Metoclopramide can cross the blood-brain barrier, so it affects the CNS as well. And it is a dopamine antagonist. So you know, dopamine is a very important thing in our brain because in let's say in Parkinson's disease, it's because of the dopamine that is because of low dopamine, you get the dyskinetic Parkinsonian symptoms. So here we are inducing the same thing using a drug. So it also causes dyskinesia because it reduces the activity of dopamine in our what nucleus basal nucleus. Serotonin antagonists act both centrally and peripherally. It's true. Serotonin receptors are everywhere now. In the brain, in the outside, I told you GI and everywhere. D2 receptor antagonists have superior anti-inflammatory effect compared to 5-HT3. False. 5-HT3 is a serotonin antagonist. Serotonin antagonist, so for example, ondansetron has far more better activity than D2 receptors such as what's that, metoclopramide, domperidone. Those things have less thing. 5-HT serotonin, like ondansetron, has more effect. You can use it for moderate to severe vomiting as well. Pyridoxine used to treat vomiting in pregnancy. It is true. It's a vitamin B6. It is given to prevent, I think it is prevent that Wernicke encephalopathy. I'm not sure. Urinary retention is side effect of hyoscine. That is true. Hyoscine is a muscarinic antagonist. You know that any kind of rest and digest activity is controlled by muscarinic activity. So if you give a muscarinic antagonist, you can't defecate, you can't urinate. So those things will be there. Omeprazole is a proton pump inhibitor. So it blocks the H plus K plus ATPase in the stomach. Here they are saying is histamine blocks histamine receptors. That's false. That would be like cimetidine, ranitidine, famotidine, those kind of stuff. Administer 6 hourly. False. Omeprazole has a very long action. They like works throughout the day. So you just have to give one tablet a day. Prodrug, that is true. Stable acidic pH, false. So that is why when you're giving omeprazole, you are using an enteric coated tablet so that you protect it from the gastric acidity. It is more metabolized in the liver. Most of the drugs are metabolized in the liver. So, yeah. Following a true regarding anti-motility medicines. Anti-motility medicines are used in temporary measure to suppress GI motility. That's true. When they are like severe diarrhea, you can give like codeine or loperamide. You can give to reduce the motion. Loperamide is well absorbed in the intestine. That is false. Loperamide acts on the opioid receptors, but it is less well absorbed than other opioids. And it does not cross even if it crosses the blood-brain barrier, it can be removed by a certain glycoprotein, P glycoprotein, something. Because of that, it has less effect, CNS effect in our body. So you can remember it like that. That's why you are giving loperamide for this kind of thing. Partner ammonia compounds cause smooth muscle relaxation because they act on M3 receptors, it seems. Constipation, adverse antimuscarinic. I told you again, you can't defecate, you can't urinate. Antimuscarinics can be safely given to diarrhea patients suffering from paralysis. Wrong. Already the patient has a paralysis. Already the intestine and everything is not working. So if you give an antimuscarinic, it will not work at all. So there will be like intestinal obstruction. It's a surgical emergency. So it's like very bad. Regarding ORS, glucose in ORS is intended to correct malnutrition by providing energy. Wrong. ORS has glucose. It has glucose, sodium, potassium, chloride, and citric. Okay. But here the glucose is actually there so that the sodium is properly absorbed into the body, not to give energy. Because there's SGLT2 inhibitors, no? So it's a sodium dependent SGLT2 receptors, channels. So they need glucose to reabsorb sodium. We are using actually it is sodium to absorb glucose, but we are using it for the opposite purpose. We are giving glucose so that we can reabsorb sodium. So when sodium is absorbed, along with it, water is also absorbed back into the body. Because of that, there will be less volume of diarrhea going out, less duration of diarrhea, and the severity will be also low. So it's a good thing. XY CAMP dependent transport false. It's SGLT1 and the sodium. Reconsider with sterile water. No, you don't have sterile water at home. No, you just boil your water, cool it down, and then you can make ORS. That's false. Isosmolar when reconstituted, that is true. So when you add the proper amount of water to it, the osmolarity of the solution is nearly equal to our body's osmolarity, I think. I'm not exactly sure. I have to check it. Has trisodium citrate as constituent? That is true. Some people say sodium citrate, but it's actually trisodium citrate. Now we have come to the micro part. So it's pure theory. Regarding pneumonia, should be instructed not to wash mouth before sputum collection. True. False. They should wash their mouth because we are trying to get their sputum, not their not the not what's inside their mouth, basically. Their spit. Mycoplasma pneumonia was typical community acquired pneumonia. It is atypical but community acquired pneumonia. This is also known as a walking pneumonia. No? Streptococcus pneumoniae is a gram-positive diplococcus. That is true. Chlamydia trachomatis is a positive agent. This is kind of a confusing one for me because it is actually Chlamydophila pneumoniae, which is a common positive agent. But Chlamydia trachomatis can cause pneumonia in neonates. So it's a bit of a confusing thing. I don't know. I put true. I'm not sure. Should be false. I think I'm not sure. Carriers are a source of Legionella pneumophilia. False. Legionella pneumophilia is usually spread by water systems, ACs in hotels, okay, because of the aerosolized infected water. So, which is the following pathogen prevented by vaccination? This theory: JE virus, Streptococcus pneumoniae, that is pneumococcal vaccines. That is what the hell? Preventable by vaccination. Why is it false? Okay, this is true. Streptococcus pneumoniae, pneumococcal vaccines are there. Okay, it's true. Listeria monocytogenes is false. Herpes simplex is true. That is false. HIV, Haemophilus influenza B, that is true. Regarding UTIs, urogenital infections are caused by bacteria of fecal origin. That is why, mostly it's like that, no? Like E. coli, enterococci, Streptococcus, Staphylococcus epidermidis, Saprophyticus, and those things. So those things, and Enterococcus fecalis, Enterococcus faecium, all of them cause like that. So in urogen phase, E. coli uses P. life bacteria, that is true. So that's how it attaches. E. fecalis does not cause community acquired UTI, that is false. Especially it's common in women. Okay. Pseudomonas aeruginosa is a cause of hospital acquired UTI, that is true. Staphylococcus, you have heard of. Saprophyticus causes UTI, young healthy females, that is true. Regarding infectious diarrhea, rotavirus replicates in the intestinal epithelial tissue cells, that is true. E. coli is a specific strain of E. coli, which can cause bloody diarrhea as well as hemolytic uremic syndrome. So in that syndrome, you have a kidney injury, anemia, thrombocytopenia, so many other things are there. Like, yeah, uremia. So those things, just giving antibiotics is not enough because there is some other huge issue there. So you might have to do hemolysis. Sometimes you might have to monitor that patient for other like blood counts. Salmonella typhimurium exclusive human pathogen, that is false. Campylobacter jejuni is spread by direct contact. That is also false. Campylobacter jejuni is like a fecal-oral spreading or something like that, or through poultry milk, like unpasteurized milk. So through those things, it's spread. Clostridium difficile causes invasive form of diarrhea. No, it releases a toxin. That toxin is the one that causes diarrhea. It does not go into the cell. It just stays on the cell, outside the cell. Regarding tuberculosis leprosy, which is the milder form of leprosy, where the patient has proper immunity. So it's highly transmissible, false. Children won't get affected, that's also false. Slit skin smear causes few bacteria, yes, that's why it's known as paucibacillary leprosy. Isolation of leprae from culture is used, no. It takes a long time to culture it. Even the half life, whatever the population half life, something's there. No? So even that is very long. Is eradicated in Sri Lanka? No, it's still there. Which is the following appropriate when there's a delay in transporting? So you should not freeze blood samples and CSF samples because there can be blood infections and CSF infections caused by Haemophilus influenza B. Okay, so that dies if you freeze it. So you should not freeze blood sample or CSF sample. Sputum for Mycobacterium tuberculosis you can freeze because it survives anything. Mycobacterium tuberculosis. Urine sample you should refrigerate because to prevent other bacteria from overgrowing. Feces sample also, it has lots and lots of bacteria. You only need a specific bacteria to identify it. So you don't need the other bacteria to suddenly grow up and cause other issues. So that's false. Regarding HIV, HIV2 progresses to age lower than HIV1. That is true. HIV1 is the actual most dangerous one. HIV2 is more slower. It's a bit of an atypical thingy. Belongs to family Retroviridae. That's true. Main target cells is CD4 cells, helper cells. So it's false. Can occur through breastfeeding. Yeah, like sexual intercourse, breastfeeding, vertical transmission through the placenta, IV injections, organ transplant, anything. Opportunity infections are uncommon. No, all the infections, most of the issues are because of those opportunities infections. Here are some of them. You can go through it. Regarding viral hepatitis, hepatitis A through fecal route, that is true. BC are different things like B is through drugs, sexual intercourse. Yeah. C is also fecal, I think. Yeah. B virus is a double-stranded DNA genome. Yeah, that is true. Host response is more important than infection pathogens. That is true because there is a virus there. No? So our body thinks there is some dangerous thing there, and we try to fight it in our liver. That causes inflammation. That causes hepatitis. So many issues. So it's not the virus that is directly affecting us. Hepatitis D infection can replicate independently. No, only if there is a Hep B infection can there be a Hep D infection. Without Hep B, there cannot be a Hep D. Hep C infection is most asymptomatic. Yeah, that is true. But Hep C can go into chronicity in a very high percentage of people. Let's say 5 to 10% people of Hep B go into chronicity. 50 to 60% or something can go to chronic hepatitis in Hep C infection. So about herpes virus, HSV spreads retrograde along the peripheral nerves to the brain. That is actually true. So that is why HSV can cause HSV encephalitis in certain people. Gingostomatitis is more common with HSV2 than HSV1. That is false. HSV1 is mostly in the oral side. So oral, pitlow, and those things are mostly HSV1. HSV2 is mostly genital herpes. Mostly, but it can also cause oral ulcers as well. Varicella zoster identified by clinical examination, typical rash. That is true. That is a vesicular rash. It's kind of like a water tube on flower petal, rose petal kind of appearance. Genital infection by just 2% as a canker. No, it is a painful shallow ulcer. Cankers are found in syphilis. It's a painless ulcer. HHV8 is associated with carpocyte. That is true. Regarding tinea infection, which is a ringworm infection, it's a dermatophyte infection, tinea, like cruris, capitis, unguium, whatever. They're subcutaneous? No, they're superficial infection. Only on the superficial tissue, like epidermis, you find it. Epidermis. So infection caused by epidermophyton species, yes. Also trichophyton, microsporum, all of them come under dermatophytes. Can be infected by domestic animals, true. Human to human, animals to human, from soil, you can get it. Infection is named according to the affected site of the body. Yeah, that's what I told you just now. Saline mounts are used? No. For fungal mounts, you use KOH mounts because if you take a sample, there will also be bacteria and other things, no? So use KOH to destroy the unnecessary cells around there to only see the fungal filaments. Measures to control health associated infection that you know, no? So air conditioning does not matter. Hand hygiene should be good. So that is true. First one is false. Promoting antibiotic use, false. You should limit it to the only when you need it. Proper management of hospital-based waste, that is true. Adequate sterilization should be there so that you don't spread one person to another person. Regarding sepsis, what is sepsis? It is the organ organ dysfunction, the widespread organ dysfunction due to dysregulated host response due to an infection. So because of the infection, our body thinks there's an infection, so we should act against it, and we do a very huge inflammatory reaction and so many things that can damage our own organs. So that's the sepsis. Mental status of the patient. So that is all. The first one is true. Mental status is not considered false. You should consider the GCS score or whether he has a normal mental status in when you're assessing. Arterial blood gas required to calculate so far. Yes, here is the things that are found in so far. So here you can see PaO2 over FiO2. That ratio for that thing you need an arterial blood gas score. Well, these are the other things you need. You don't have to memorize this. Just have a basic idea. GCS score, creatinine, urine output, pressure, those things. You just have a basic idea. ARDS is a complication. Any kind of inflammation can be a complication. Antibacterial therapy should we wait? ABST? No. It's in the first hour is known as a golden hour. So there, during that time, you should do most of the things to prevent the patient from going to a shock or anything. So that's a sepsis 6. So on sepsis 6, you should give 3, take 3. So you should take blood sample, give antibiotic immediately. So only have to take blood sample. If possible, take blood sample and give the antibiotic. If you're unable to take a blood sample, it's fine, give the antibiotic because you need to save the patient. You should not wait until the results come. And then fluids, oxygen should be given. You should take blood for all blood reports like blood culture, ABG, lactate, serum electrolytes, everything. So you should take blood for that. And then you should monitor the urine output. So should not. So E is false. 60th one is management of hyposplenism include. Hyposplenism means that the spleen is not working properly, or like you remove the spleen. You've done splenectomy for some issue. So because of the spleen helps us to protect ourselves from encapsulated bacteria. So if you remove the spleen, then you need to give protection against common encapsulated bacteria. So as well as malaria. So you should give malaria prophylaxis, antibiotic prophylaxis, vaccination against Haemophilus influenza B, common in the society. So pneumococcal vaccine should be given, Haemophilus influenza B vaccine should be given, meningococcal vaccine should be given, influenza vaccine. So those are some of the prophylaxis we do. So Bordetella pertussis vaccination is not one of them. So that's false. Hepatitis A is also false. So here, this slide shows what are the things that you should do. Antibiotic prophylaxis, pneumococcal vaccine, H influenza B vaccine, meningococcal vaccine, influenza vaccine, malaria prophylaxis, antibiotic prophylaxis before dental procedures. So these are some of the things that you do. So that's it. So I've taken a bit more time. I hope I've at least told you something that you didn't know before. It's if you find it that you couldn't understand anything, you can just message me or something like that, or put in a group. I'll go through it and send it to you later. Issues the time constraint is the only reason I had to go so fast. So if you have doubt, you can ask even. I think there. Okay, right? Okay. See you. Manit will be doing the SCQ discussion. So I don't know how he'll be doing it, but mostly around like how to answer SCQ, like what is the order you should write or something like that. I'll share this document to the group. Okay. Thank you.